we are going to dive in a little deeper into ocular presentations, right? So we're gonna do a bit of a deeper dive today into those presentations and learn some new terms, right? We're gonna learn some new presentations that we're gonna need to be aware of. I added slides to the presentation from yesterday, obviously. Obviously, once I have everything that I want here, I will post it for you, I promise. But I wanted to add a few things in. But guys, this is gonna be, I'm excited about this. I really feel like you guys are going to learn a lot, you know, at least in regards to different types of ocular malfunction, and it's just going to be fun, and you're just going to love it. Maybe not, but I like it, and I'm just kind of assuming that you will too. All right, let me share my screen here, folks, and we'll get after it. All right. Doobie. Sorry. Come on. Okay. So obviously, guys, just reviewing, we started off yesterday talking about obviously the 10 R's, right? Not the 11 that obviously govern concussion recognition, management, and risk reduction, right? But the one thing that we said is we covered the fact that, you know, most symptoms tend to resolve in 10 to 14 days, right? And we know about this discomfort is CAT5, 22 possible symptoms, total possible severity score of 132, right? However, if we remember, right, the people that fall outside of that category are said to be experiencing protracted recovery, right? So, hello, somebody just jumped on in. All right, so ultimately, right, we also talked about the fact that those that don't have a significant history of concussion tend to have, you know, a fewer number of symptoms and less severe symptoms on the SCAT5, at least on the symptom scale, as opposed to those that have had a history of concussion, because these people tend to present more often with symptoms that are not only more severe but greater in number. Okay, so we got in also to these symptom clusters, okay, or subgroups, right? Vestibular, ocular, mood, anxiety, and then cognitive fatigue. And you know, we also said that originally there were 6 symptom clusters that were originally described, including migraine and or, you know, persistent migraine / post-concussive headache and or cervical symptoms, right? And who remembers, guys, that we talked about yesterday? One of the most common, what are the 2 of the most common, and this happens really with all of them, but which one are the 2 most common as far as crossover that we see between these subgroups? Generally speaking, what's the most common that we're going to see? Who remembers?
Ocular, vestibular.
Yeah, thank you so much, Bella. All right, very good. Love it. Okay, friends, prepare yourselves. This is going to be like mind-altering, maybe. Let's give it a whirl. Okay, obviously, you know, we talked about obviously the utility of the bombs, and obviously that crossover. Okay, here's the deal. Ocular profiles, friends, this is where the rubber meets the road. In order to get really good, right, at identifying these profiles, we need to understand some basic definitions, okay, about what it is that the eyes do, how they move, right, and then some alterations to that movement that are, you know, permanent, right, and or functional. So obviously convergence, okay, if I'm converging on a target, okay, that's my ability to bring my eyes together, okay, to focus on a near object. And you guys tried this with me, you know, when we were measuring your point of convergence, right? I was looking at that 14.5, watching that object come near to my face, right? And establishing my ability to focus on that, right, at midline. And then we measured the distance, okay? So conversely, whereas convergence is the ability to turn my eyes in, right, to focus on an object, divergence, conversely, is the ability to turn my eyes outward to look at a distant object. Okay, so skinny, big, narrow, wide, right, near, far. All right, okay. So what about accommodation though? Okay, what in the world is accommodation? Now, Bella, you asked the question yesterday. Okay, you asked the question yesterday when we're performing near point of convergence measurements. Why can't we just start close and work our way out? right? Because ultimately, the ability of the eyes to accommodate and focus on a near object may actually alter and or change the measurement on your point of convergence, right? So we always start at far and move towards near, because the definition of convergence is the ability to focus on a near object, right, from afar, bringing it towards. Okay, what I've done today too, and I think you guys are going to love it, is I've put in a couple of really awesome videos that are going to actually explain the difference between trophias and phorias. Oh, I'm so excited about this. But okay, trophias, right? So ocular malalignment. So when you look at someone, when you look at their eyes, okay, if you look at their eyes and ultimately, if you're sitting there looking at them, okay, if their eyes are lined up and look good, right, that's great. But what happens if the eyes are not appropriately aligned? Okay, what if they're malaligned at rest? Okay, and or with visual field testing, which you guys are going to see in a second. Okay, that's called atrophia, right? So an ocular malalignment that's exacerbated by visual field testing, okay, with a noted limited or complete inability to move in a cardinal direction. Let me explain that. So when I say cardinal direction, so remember, and you guys are going to hear this a lot when we see these videos that we're going to go over in a sec, right? Remember that when we're doing a lot of our visual field testing, what cranial nerves are we really looking at with this? Well, with visual field testing, we have two, right? Cranial nerve 2. When we're looking at ocular movement, both horizontally and vertically, what nerves are we looking at? So that was 4 and 6, Bella. Is that what I saw? Okay, thank you. All right, cool. Okay, conversely, aphoria. Okay, this is an ocular malalignment that's functional in nature, right, and resolves and or is temporary. And what you guys are going to see here in a second, right, is that this is typically noted with something that we call the cover-uncover test or the cross-cover test, and I'll show you that. Okay, so much fun. If you guys have questions, stop me, please. All right, if I'm moving too fast. All right. Okay, now here's the deal, guys. Before we jump into these, remember, right, when we're talking about these ocular profiles, okay, we have nystagmus that we always have to keep in mind, right? And remember, like we talked about yesterday, the presence of nystagmus, right? This is one of those symptoms that really represents a really close crossover between ocular presentations and vestibular presentations. The reason for this is that, remember, the point of the vestibular ocular reflex, right, is to be able to maintain gaze on stationary objects while moving the head, right? It's to keep those objects stable in the field of vision while moving the head, right? But if we have, for example, a vestibular type of presentation, ultimately that can actually cause nystagmus if we're doing too much head movement and or if we change position as far as posture goes. Okay, and we will talk about that in detail when we get into vestibular function. Okay, so here's the deal. Nystagmus, right, as we often see, can occur at end gaze. So when I say end gaze, what in the world do I mean by end gaze? All right, end gaze nystagmus. If I'm doing obviously visual, if I'm just checking smooth pursuits, okay, and you see that beating nystagmus at the end range of my vision, at the far left or the far right, okay, that's end gaze nystagmus. There are times though when you will see mid gaze nystagmus. All right, and just a word to the wise, if you see mid gaze nystagmus with other like potential central presentations and or deteriorating symptoms, right? So when I say deteriorating symptoms, what do I mean by deteriorating symptoms? Who can tell me? Who remembers? Okay. All right, so deteriorating symptoms, remember guys, so obviously we have someone who is, experiencing concussive symptoms, but headache, nausea, potential changes in obviously arousal awareness, and those things are actually starting to rapidly get worse and progress. Okay, those things are considered deteriorating symptoms. And so seeing mid-gaze nystagmus in the context of deteriorating and worsening symptoms means that they need to be referred ASAP, right? Particularly to the ED for a scan to make sure that there's nothing going on that we may have missed, like a bleed or those types of things. Okay, all right. So I will leave that alone and we'll move on. I see people are still writing potentially and or looking. So I will leave this up for just a second.
Will this be on Moodle?
Yes, sir, it will. Yeah, I had to add slides, and as soon as I get all the slides on this thing that I want, I promise you I will post it. But yes, sir, the answer is yes, it will be. Yep. All right, friends. Here we go. I just love this. Here we go. So a little bit of YouTube Fear Friday. I do hope that you enjoy. Okay. Sit back, relax, drink your drink, and learn. Oh. Can you guys hear that, first of all? Okay. I'm glad I asked now. Let me fix that. All right.
I think we're going to continue now. You guys are ready? The next topic is tropias versus phorias. One of the difficult things we have in the eye doctor's office is the patient that comes in complaining of double vision. I mean, it's a nightmare for everyone trying to figure this out, and it usually slows our clinic down just because it takes a while to tease out. I actually like neuro-ophthalmology a fair amount because unlike most of what we do, which is image recognition, can you recognize a corneal ulcer? Can you recognize glaucomatous cupping in the back of the eye? This actually takes a fair amount of reasoning to do. And for that reason, it's not a fun topic traditionally, but we're going to see if we can do this. But there's really only one goal with this entire lecture, and that goal is to figure out what's the difference between a tropia and a phoria. Now, this looks like a complicated definition, but this is the best one I can come up with. And this is what is written in your notes. But the idea is that a tropia is a misalignment between the eyes. It's always there. It may be obvious. It may not be obvious. But a phoria is something quite a bit more subtle. So, for example, if you have two patients, one of them comes in and says, you know what, I woke up this morning and I've got double vision. Look at my eye. And you look at their eye and the right eye is turned in towards the nose. This is a large tropia. It's always there. It's very big. Compare this to another patient who comes in and says, you know what, I get tired in the evening for the past few months. I start to see double when I'm looking at the television screen. And their eye looks normal. This could be a tropia, but it could be a phoria. And so let's explain the difference by actually looking at some cases. Now, once again, I could have animated this entire lecture like I've done for some of my neurology lectures. However, it's very time consuming. And I wanted to show a whole bunch of examples, and it would take me a month or so. And so what I did was very similar to the last lecture. I basically created a cardboard cutout of a couple of eyes, and using my camera and some basic animation techniques, I've come up with this device. And I call this the eye monster because he's got eyes that are going to move in very funny ways, and we're going to try to figure out what the problem here is, how to name it, how to recognize it, and that's about it. Our job here is not to find the cause. I'm not looking, is that a third nerve palsy, is it a fourth nerve palsy, is it decompensated exotropia? We don't need to know that stuff. We just need to know how to recognize it and document it. So we're going to begin with some easy stuff, the basic tropias at primary. And when they're very large, they're quite obvious. So in this case, it looks like that left eye is deviated outwards. And when the eyes are deviated outwards, we call that an exo. This is an exotropia. Not too hard. In this case, the right eye seems to be pointing towards the nose. This is an ESO. When the eyes are turned inwards, it's an esotropia. A pretty big one is quite obvious. Now, when one eye is pointed up, in this case, it looks like that left eye might be deviated upwards. We call this a hypertropia. And when one eye is deviated down, we call this a hypotropia. That's the basic naming conventions. Now, it doesn't really matter so much what primary gaze is because we're going to talk about some more interesting stuff. How do the eyes move and how does that change these things? Now, this is an exotropia. The left eye is deviated outwards. And for the most part, it's deviated outwards a little bit on all directions of gaze. You know, a lot of people who are, say, born with a ocular motility issue or even develop some type of palsy, like a sixth nerve palsy, if you give them enough time, they become comitant, which means that the problem, the exodeviation is there pretty much in all gaze directions. But we're going to talk about some more interesting things. Let's talk about some tropias, some very obvious misalignments that we only see with different directions of gaze. So for example, in this eye, straight ahead, great. So that looks fine. But if you had them look off to one direction, you notice that that right eye is not getting out. In fact, you might even say that that right eye becomes esotropic. It's cross-eyed, at least when they try to look to the right. So one way to describe this would be a right esotropia. But we'll come back to that, because what we need to talk about if we're going to talk about eye movement disorders is the cardinal directions. Now, let's do some basic eye anatomy. As we know, the eye sits inside of the eye socket like a scoop of ice cream inside of a waffle cone. And there are rectus muscles, which do up, down, left, and right, which attach to the surface of the eyeball and go all the way back to the back of the eye socket at the annulus of Zen. And these rectus muscles, at a very simplistic level, affect the eye direction in this way, up, down, left, and right. But the reality is that the eye socket is a little bit more complicated than this. There are some other muscles back there. There's the obliques, the superior and inferior oblique, which do some funny things. In fact, the superior oblique, the trochlear muscle, fourth nerve palsies hit this, actually has a little pulley up in the bridge of the nose, and that pulley changes the direction. It can cause some very complex things. This is not important, but what is important is that the skull of the human is not like this diagram. We are not robots, up, down, left, right. We are not like that. In fact, if you look at the skull of a horse, their eye sockets are pointing outwards. And the reason why is because they need to see potential predators that might come and try to kill them so they can run away. If you look at a more violent creature, such as this small cat, their eye sockets have rotated forward and they're facing forward so they can see their potential targets of prey, or milk in this case. So what's better than the cutest kitten in the world? Pretty much any dog. And so this dog also has eyes pointing straight ahead. Of course, the biggest predator of all time is the humans. We're top of the food chain. If you look at our skull, for the most part, it's pointing straight ahead, but it's not really. In fact, if you look at a CAT scan of a human skull, you'll see that the waffle cone, the eye socket, at least the medial walls near the nose are pretty much straight ahead. But the outer walls of the eye socket actually shoot off at a 45-degree angle. So it's not quite straight. And because of that, when the superior rectus attaches to the eye, it doesn't attach, well, it attaches in the correct location, but its action isn't a pure up and down. There's a little bit of a twist. It's slightly out to the side. And so if you actually look at the gaze directions, it looks a little bit more like this. And this is what we call the cardinal directions. It's not up and down. It's slightly to the left, slightly to the right. So when we check eye muscle movements, we don't usually go up, down. We do, but it's more important to hit the cardinal directions. And this is how we do it. So back to our eye monster, we always start with primary. I typically go left and right just because you pick up a lot of issues with left and right, because a lot of things are ESO or EXO. And then I make a box, a square. So I start up on top, crossover, ignoring the straight up for the most part, and I complete my box, and we're back to primary. So this is how we do the basic cardinal directions. And how would you chart that? Well, you could have, like we already described, said that was a right esotropia. They go cross-eyed when you try to look to the right gaze. Another way to chart this is actually write out the cardinal directions like a cross with a line through the middle and put a percentage where 100% is normal, 0 is no movement. And this is one way that I document basic large angle issues like this. Another way you may see, depending on your doctor, is they may write it like the big H, because the H's are technically left, right, and then the 4 corners of that box. And with this scale, 0 is normal, -4 is no movement. And when it's a plus number, it's an overaction, but we'll see some examples of that. But let's look at another eye. Straight ahead, primary, everything looks good. Let's do our cardinal directions, look up to the right. Whoa, that left eye didn't get out there, did it? Okay, everything's okay in this direction, but let's look over here again. Once again, it's not getting out there. We'll do our box, hit all of our cardinal directions, and it looks like that left eye can't quite get towards the nose. The eyes are a little wall-eyed. We'd call it exotropia, right? That's apparent with right gaze when they try to look to the right. It's really the only time we see it. Or it might be more accurate just to write it out. You know, if you don't want to name these things in your head, you'll get confused. Just write them down. You can think about it later if you want. But this is how I would write out that eye muscle problem. Let's look at another eye. Primary, everything seems okay. All right. Let's do our horizontal gaze. Okay, that looks fine so far. No issues there. And that looks fine. Okay, let's do our box. And we go up there. Look at that left eye. It's not quite getting up as high, is it? So that left eye is not getting up. So that means that left eye must be hypo. It must be too low. It's a hypotropia that's really only apparent with up gaze. And we might write it like this. When might you see something like this? Well, a lot of patients who have thyroid problems in the eye, thyroid affects the inferior rectus muscle, fibrosis, and the eye gets tethered. They have a hard time looking upwards. So that's a case where you might see something like that. Here's another eye. I primary, we're good. Let's do our left and right horizontal motion. Everything looks fine. Whoa, what was that? See that left eye? It did something funny there. Watch that left eye carefully when it looks off to this direction. It seems to shoot upwards a bit. Now that's an odd look. So over here, it's maybe up a little bit, but for the most part, back to normal, but it shoots up maybe a tiny bit at the end there. So that's interesting. That left eye shoots up. It's a hypertropia because it's going upwards. And you only really see it when I look off to the right. So this would be a left hypertropia with right gaze. We might write it like this, 140%. It seems to shoot upwards. Another way to write this would be like a +2. When would you see this? Well, if you have a fourth nerve palsy, you'll sometimes get this funny upshoot like that. A lot of kids with congenital esotropia or other issues have what we call inferior oblique overaction. It doesn't matter the names of these things because our goal is not to describe what's causing it or just documenting it. We can think about it later. Spend all night thinking about it. As long as you write it out, the percentages, you can figure it out later. But let's talk a little bit about smaller tropias. And this is where most of us, I think, have the harder time figuring it out. So far, everything's been obvious. But what about this case?
All right. So this, okay, that was basically, those are examples of tropias. What we're about to see, though, is a lot more subtle things that we definitely will see with people that have concussion. Okay, get off this for a second. Next one. There we go. Perfect. All right, here we go.
About it. As long as you write it out, the percentages, you can figure it out later. But let's talk a little bit about smaller tropias. And this is where most of us, I think, have the harder time figuring it out. So far, everything's been obvious. But what about this case? The eyes seem to be straight ahead. But this patient says, I had double vision for days now. Look to the right, things look good. Look to the left, things look good. Let's do our cardinal directions. We'll hit the box. Eyes seem, for the most part, to move in all directions is not obvious. Now we're going to do something called the cover uncover test. Okay, no movement. That left eye is locked on solid. Nothing wrong with the left eye. Let's check that right eye. Oh, that little correction movement. When you cover, that right eye moves out. It corrects by moving out. What that means is that right eye is a little pointed towards the nose. When you force it to work, it corrects by moving outwards. This is a right ESO inwards tropia. Small angle. We could figure out how much that angle is by holding prism, but we're not going to talk about that. Let's do another example. I've got double vision. All right, let's hit our primary gaze. And we're going to do our cardinal directions. I always go left, right, then I hit the box. And so far, things look pretty normal. Pretty much normal eye movements. Okay, let's do our cover uncover test. Cover, look at that little correcting movement. That left eye must be pointing too far to the side. And when you force it to look, it looks like the right eye dominant. So that one's pretty much locked on all the time. Let's do a replay. We'll cover that other eye. This is a left exotropia. The eye is too far out, and when you force it to look by covering a good eye, it comes inwards. A left exotropia. Okay, another example. Primary, everything's fine. Good. Do our horizontal axes. Okay, that's fine. Let's do our cardinal positions. We'll hit the corners of our box. Everything is okay. Nothing's obvious yet. Okay, but I still have double vision. Let's be cover uncover. Cover. Oh, look at that little correcting movement. That left eye comes down. That must mean that that left eye is pointing too far up. When you force it to look, it comes down. The right eye is locked on solid. The right, it must be right eye dominant. But when you correct that, it comes down. And it's these little flick movements that really can tell us a lot. So this is a left hypertropia. Okay, let's do one more example. Primary, everything looks good. I've got double vision though. All right, well, let's do our side to side. Everything looks fine. Let's do our cardinal positions. Everything looks good. Okay, let's do our cover uncover test. Here we go. Cover, nothing, nothing. It must be left eye dominant. That left eye is locked on solid. Let's check the other side. With that little correcting movement, moving upwards, must mean it's too low to begin with. And so this is a right hypotropia. Right. So far we've been talking about tropias, and tropias are there pretty much all the time. One way to think about it is I've got double vision, even with both eyes attempting to lock onto the object, I still have double vision. Aphoria, on the other hand, might only be there some of the time. You may have to tease aphoria out to bring it on. This is the patient that says that I start getting double vision when I'm driving at night on the car for late night, I'm tired, and then the roadside start to split. These are more subtle. Here's an example. Primary gaze, everything looks good. Side to side, everything looks good. You always got to start with primary, and you got to do your cardinal directions at the beginning. This is basic stuff. So we do our cardinal positions, things look good. Let's do the cover uncover, see if we can pick up a small tropia. No, things are locked on pretty good. That left eye is locked on. The right eye is locked on. Let's break fusion now between the eyes. Don't let them synchronize with each other. We're doing the cross cover test. As we cross, you can see the eyes are correcting by coming in. And what that tells me is that when you break fusion, you don't let the eyes talk to each other. The cross cover test, they have a tendency to drift out. They have a tendency to be an exophoric. They have an exophoria. And you can only really tease that out with the cross cover test, break fusion. Break fusion, that's a buzzword. So let's go on to another example. I've got double vision sometimes. I'm not comfortable reading, all right. Well, we'll check our primary, we'll check our cardinals in all directions. Everything looks fine. Let's look for some tropias. We'll do a cover on cover test. Eye is locked on solid, everything's good there. Cover on cover. Locked on solid, there's no tropias at all. Let's see if we can bring out a phoria by breaking fusion. And we see that, we see, oh, a little correcting movement. It's coming out. It's coming out. What that tells us is that the eyes have a tendency to cross. They have an esophoria that we brought out. You can see it because of the correcting movement. Another example. I've got double vision. Things look kind of catty corner, doesn't look quite right. Okay, well, let's check it out. Cardinal directions, everything looks fine. Let's do our cover uncover test. You always do that one first. Look for tropias. Everything's fine there. Locked on solid. Locked on solid. No tropias at all. Let's see if we can bring out a phoria by breaking fusion between the eyes. A little correcting movement there. Look at that right eye. The right eye comes down. That must mean that the right eye was too high. This would be a right hyperphoria or a left hypo. It's hard to, when it comes to up and down, you can describe it either way, but I find it more useful just to concentrate on the right eye when it comes to these things. So it was a hyper. Let's move on. One more example of this. Double vision sometimes, either way, but I find it more useful just to concentrate on the right eye.
All right, guys. So here's the deal, right? Why go through that? Like, what is the point of being able to recognize a tropia versus a phoria? Okay, here's the deal. The reason why that's important, is because we have to be able to essentially recognize, right, these, because these will inform our treatment. Okay, and I promise you guys, if we get good at, and we will practice these, but if we get good at identifying them, that will inform our treatment. I promise you that if you can do this, you could work at any specialized concussion clinic anywhere. TRIA, okay, UPMC, you can do it, right? So that's the reason why I'm showing you guys this now, because this is an incredibly important thing to be able to tease out, particularly on your ocular exam, okay?
About it.
Well, there we go. Obviously, right, so near point of convergence, we talked about this yesterday, right? So this is obviously part of the bombs. Anything, greater than 5 centimeters is abnormal. I will correct that and do that right now. So obviously, what are some exercises we did yesterday to try to address near point of convergence? What did we do?
Pencil push-ups.
There you go. Okay, pencil push-ups. Okay. Now, what's the one thing that we saw with me yesterday when we did pencil push-ups? Did my near point of convergence get better or worse? Who remembers?
Got worse.
Got worse. Okay. Now, that's not uncommon to see after doing those types of exercises. However, one thing that we could have also done is actually held the object at a stationary point and essentially made me focus on the object without moving it towards my nose, right? And so essentially progressing and starting that as stationary, right? And then moving towards more dynamic movement is something that we definitely could have done. But remember, right, when we're doing these exercises with patients, these should be done at a sub-symptom threshold. So if we are eliciting symptoms with these exercises, okay, then that means that we're pushing the patient in a little bit too much. Okay, so we need to be really careful there. All right, the Brock string, yay fun. And I know you guys, we have these downstairs, and we'll go over obviously in more detail how to use these as well. So obviously, if you've ever seen a Brock string, you know, right, that these are actually laid out with different colored beads at different lengths, right? So, and ultimately, you can instruct a patient to essentially focus on one bead at a time, right? And so let's say that I'm focusing on the furthest bead, on the yellow bead. What I should see, right, when focusing on the yellow bead is essentially basically 2 green beads, even though there's one, right? So I'm essentially focusing on convergence, right, at a far distance. So green beads should be double, red beads should be double. Okay. But if I choose to focus on, right, the green bead, okay, ultimately what we'll see with this is that the yellow bead will be doubled and the red bead will be doubled. Okay. And then if I were to focus on the red bead would be obviously singular with the green bead and the yellow bead doubled. And we will actually work on this more in class, and we will kind of further tease this out and explain it. Okay. Okay, guys. So that is it for today. Wanted to make sure that we kind of were able to take a bit more of a deep dive into these, but we will obviously continue to get experience with these and practice them in the coming days. Okay. And I will have more details out to you guys about Monday this afternoon in regards to what to expect. Mary and I are going to be in meetings pretty much all day on Monday, pretty much all morning. But I will let you guys know what we're going to do and what to expect for Monday as far as class. Okay. Yeah. So the other thing too, guys, because of our site visit on Monday, I will actually be back in St. Peter late Sunday afternoon. So if anyone would like to or needs, I am willing to definitely just kind of do some informal review with you guys on Sunday night, spend time going over things, going over concepts. Happy to do it. If you want to spend some time reviewing together Sunday night, or I'm happy to do that. Just let me know. So I can definitely make myself available if you guys need help. All right. Okay, guys. I hope you guys have a great Friday and a great weekend. One more week until spring break. Everything's going to be okay. I know you guys are kind of at you look like you're about done. So we're going to go ahead and call it a Friday. So have a great day. Okay. If you guys need anything, let me know.
Thank you.
Yeah, of course.